Good morning. This is Dr. Rutledge, and I'm going to be talking to you about the MGB and the MGB2. So let me share my screen and we'll get underway. So before we get started, I have a question, which is I can go ahead and do this talk, which I'm going to do on this video, or we can stop and look at the video of the surgery itself first, because a lot of people get antsy when I'm just talking for 100 slides. And so if you want, we can just stop and go to this link and see a 36-minute live MGB video recording. But since I'm just recording this as a test now, we'll keep going. And so with great power comes great responsibility, and the MGB2 has that power and responsibility under its sight. So it has less risk and more power than the other operations. Particularly, we're trying to stop leaks and bleeding. That's the main goal. But more than that, there are more benefits than that. But those are potentially deadly complications. And so here are the ideas of both the MGB2 and the MGB. This is what was my guiding principle in creating the MGB and the MGB2. And the simple philosophy of both is remove the reservoir function of the stomach. That's really simple. Sleeve and a lot of other operations do that. But the stomach we have is turned into an esophageal extension via a callus gastroplasty. One of the other foundations in mine operation is to avoid the EG junction. And fortunately, it's rare, but we know, unfortunately, there are tragic patients with complications because of dissection in the EG junction with leak and even death. So this operation has no dissection near the esophagus. And in addition, no dissection near the spleen or the short gastrics. The other thing is we want to lengthen the distance between the acid stomach and bile and the esophagus, and the new MGB2 lengthens the gastric pouch by 30 to 50%. And we want to decrease ischemia, foreign body, and a lateral gastrojejunostomy. So the avascular foreign body is a complication. It takes a little bit to explain it, but a lot of MGB surgeons or Roux-en-Y surgeons make a very ischemic foreign body filled gastrojejunostomy, and that's often a source of ulcers and other complications. We want to increase the gastrojejunostomy outlet diameter to improve dumping. We want to decrease or eliminate staple line leaks, and we want to easily make it reversible and revisable. And we'd easily tailor it for both low or normal weight diabetics up to the super obese. And we think we can do that now with the MGB2 especially. And this is what the MGB2 looks like post-op. And so you see the narrow gastric pouch and the gastrojejunostomy with rapid filling. And so it's powerful. It's short, simple, low cost because we don't use staples, decreases the risk of leak and bleeding, as well as numerous other advantages. Again, no staples or 1 or 2 staple firings, 30 minutes. It's the same day surgery. And the goals that we have met is it decreases the risk of bleeding and leaks. Resource utilization is improved, op time is improved, risks and reflux are successfully treated, and it's easy to treat thin diabetics. So it's got a lot of fun. So let's do an MGB2. And so here's the view. We'll go through that. And so here's where the junction of the body and the antrum of the stomach. And usually with the old MGB, the gastrojejunostomy would be about in this area. And that's shorter than the new MGB location, which is at the greater curvature. So we have lengthened the gastric pouch significantly, which decreases reflux and bile reflux complications and things like that. It's just one of the many advantages of the MGB2. So the first step is actually find the ligament of Treitz. We bring up the loop of bowel, and we begin to do the gastrojejunostomy by anchoring the loop here. Then we go ahead and do the staple gastrojejunostomy. And you notice that particularly that the new approach is the staple gun comes from the left-hand side, and it's perpendicular to the long axis of the patient, and it's very important. And but we'll talk about that later probably. It's some of the details of how to perform it well. Now you can see the gastrojejunostomy being completed, the staple cartridge, and the largest lumen is here. And we close up this side, and you'll see that is closed. And you can kind of get an idea here, big, narrow. This only has to bring in bile. This takes food. So this is a significant improvement. And there's another example. So efferent, afferent. Bile only, food, potatoes, sandwiches, big, versus the reverse, the way the initial MGB was invented. Now we plicate the stomach. That's the stomach's second layer, plication. We don't catch the back wall. And so now we have antrum, efferent, and afferent limb. There's the plication. Now we plicate the antrum. And now here it is, lesser curvature, greater curvature, plication. Again, this is a really important point. We have this very large gastrojejunostomy here. And again, here's the points. This is the antrum. This is distal. Then we have gastric fundus, gastric tube, free space, and then the gastrojejunostomy and the BP limb. So again, neogastric pouch is up here. We maintain the vascularity of the greater curvature. Again, the gastrojejunostomy here, antrum prior to plication. And then here's the leak test. Okay, plicated antrum. Here's the gastric pouch. And if you look at it, it looks very similar to the gastric pouch of a regular MGB, but several $1,000s less in costs for the surgeon and the patient. Here's the afferent limb. Here's the efferent limb. Okay, so MGB2, distal, greater curvature, gastrojejunostomy, longer gastric pouch, better blood supply, less reflux, less distance. And so let's look at this particular advance of the MGB2. Think of this. This is the old Mason loop, which was a tragedy. It was much too short and put bile right up into the esophagus and was quickly abandoned. A lot of non-MGB MGBers put their gastrojejunostomy here. The MGB should appropriately be here at the junction of the body and the antrum. But here's the nice thing, which is that the MGB2 puts the gastrojejunostomy here. So we have a much longer distance between bile and the esophagus. Again, here's that same picture. Here is where the old crow's foot, this is where the old MGB gastrojejunostomy was, and the new MGB2 is much further down, much better. And same thing again, here is where the proximal gastrojejunostomy for the MGB2 of the original MGB, and look at the MGB2 all the way down here. So not here at the crow's foot, but way down here. It's off the picture. So then we do an anterior plication. Why the MGB2? Minimize bleeding and leaks, cut costs, decreases risk of reflux, and it's useful for, we have found, for the treatment of diabetics and thin diabetics, because you can tailor it to minimal weight loss, but still have resolution of diabetes. Here's some post-op pictures, and we can go into more detail on that, but there's the kind of picture there, narrow stomach and rapid emptying into the efferent limb. Again, this is very important. We bring the staple gun in from the left-hand side, not the right-hand side, not between the legs. Big changes there. That's it. Thank you all very much.